Our next panel, we'll ask those that are in the room to go ahead and move to the stage, please. Our next panel is Protecting Rural Americans, Addressing Gaps in COVID-19 Vaccination Coverage. Addressing barriers to vaccination in rural areas is critical to achieving vaccine equity, reducing disparities, and decreasing COVID-19 related illness and death in the U.S. In this session, we'll hear from LaTreace Harris from the CDC, Brittney Roy from the National Governors Association, Siman Qaasim from the Arizona Department of Health Services, Dr. Matt Willis from the Marin Health and Human Services County Approach, and Dr. Keri Rath from the Fabulous Ladies Book Club. Hannah Lips was going to be with us, but unfortunately she's out ill, but her slides are available to you for review afterwards. And I see that Ms. Harris, your slides are up. You have the floor.
Yes, they are. Thank you so much. And it is wonderful to be able to present today on this extremely poignant issue of taking a look at disparities in vaccination coverage. It's something at CDC in the COVID vaccination effort that we really were trying to make sure that we were doing very, up-to-date monitoring of how vaccine was not only being distributed, but also, trends in vaccination uptake in urban and rural counties in the U.S. So my presentation today, I'm actually presenting on behalf of colleagues of mine who were the generators of this analysis, and we will be taking a look at disparities in COVID-19 vaccination between urban and rural counties in the U.S. between December 14th, 2020 and January 31st, 2022. We'll move to the next slide, please. So I just want to start at the very beginning of what we already knew prior to actually embarking on this analysis. So at the point that we started this analysis, we knew that this, first of all, was at the very start of the vaccination campaign. So vaccine rollout corresponding with the time about a week later that we actually started to assess our time frame for this analysis. So we knew that COVID-19 incidence and mortality were higher in rural counties in the United States than in urban communities. And we knew that based on case surveillance and hospital data that were coming out of CDC prior to COVID vaccination implementation actually occurring. And these disparities in COVID-19 vaccination coverage between urban and rural communities had been recognized in the past, in taking a look at some of the different trends from our National Immunization Survey and other surveys related to routine vaccination. We knew that we had seen some differences in urban and rural counties, but COVID vaccine disparities were something that had already started to be recognized as you started to take a look at some of the very early uptake COVID data. And so knowing those things, we wanted to make sure that we were taking a closer look at some of the disparities that had been speculated in the COVID-19 vaccine effort and making sure that we were able to distinguish a little bit more about where these disparities were happening and characteristics of individuals in which these disparities were being seen. So next slide. So now we'll move very quickly to what we started to find. So first of all, COVID vaccine coverage, the way we defined it within our analysis was with those that had at least one dose of the primary series, the primary vaccination series. So when we're taking a look specifically at urban versus rural for the entire United States as a whole, we see that there was a significant disparity between the uptake of vaccination coverage in urban counties being 75.4%, while in rural counties we were lagging behind at 58.5%. And so, like I said, this is something that we wanted to make sure in very real time we were also assessing different things and factors for why we might have potentially been seeing these disparities and differences in the county breakdown between urban and rural, and making sure that we were also assuring that with our vaccine distribution efforts at CDC that we were getting vaccine out of the door, making sure that there were various vaccination locations and opportunity for vaccination in rural counties as well as in urban. Next slide. So here we see that our gap between vaccination coverage in the urban and rural counties was actually 2 times more than what we had seen in earlier parts of the pandemic. So here we see on our slide, we have between April 2021 and January 2022. And so as we are looking at that gap widen over time, it was really interesting to kind of try to understand what are the characteristics of these individuals in which we're seeing this gap increase. Why is uptake in rural counties happening at a slower rate? But then also, like I said, I think the first part of it was trying to identify the characteristics of those individuals in which we're seeing this gap. Again, trying to target efforts on the ground to help impact these changes and address any disparities that we were seeing in vaccination coverage. Next slide. So what we found was that 46 states had higher COVID-19 vaccine uptake in urban areas than in rural areas. Again, this was something that we were seeing it happening in a number of states in the U.S. This was not a unique problem to any particular part geographically of the country. This was just something that we were seeing a lot. And we know that, this COVID-19 vaccination effort has been different in the sense of how routine vaccinations are provided, because a large amount of vaccine was coming through mass vaccination clinics, through pharmacies, et cetera. And so, one of the things that we really were trying to think about is, okay, let's again try to identify the characteristics of these individuals in which you're seeing the differences in urban and rural uptake. Next slide. So we did have one state that had a higher rural vaccination uptake than in the urban areas. And I believe that this difference was slight. Anecdotally, I don't think that Arizona was particularly doing anything different in terms of their vaccination planning, vaccination rollout planning than any other state in the United States. I think that this just so happened to be that Arizona actually does have some very, very large rural counties and individuals who were highly motivated to be vaccinated in those counties. And so you did see vaccination coverage in Arizona that was higher in rural counties than in urban. Next slide. And then we had 3 states that were a part of our analysis: New Hampshire, Rhode Island, and Delaware, as well as the District of Columbia, that have no rural counties in terms of how rural is defined. And so these counties were not a part of our analysis. Next slide. So overall, we found that vaccination coverage was lower in rural areas compared to urban areas across age and sex. So if we can go to the next slide, we'll move to the next. Yes, perfect. Thank you. So as we can see here, male and female differences in urban and rural counties, we see that females are slightly more likely to receive vaccinations than men. And I think this was something that we saw just nationally, but we can see the breakouts here, specifically in urban and rural counties, with the wider gap being in rural counties, where females were 61%, were receiving vaccine at 61.4%, whereas males coverage was 55.7%. We saw similar characteristics in age. Next slide. Yes. So in the 5 to 11-year-olds, of course, this was the age group that received vaccination last. So of course, you're going to see that disparity there, that vaccine was not actually approved for that age group until a later time frame. And so that, we think, accounts for a lot of the disparity that we see. Of course, we have to have a pattern and time for uptake to actually occur in the lower age groups, and making sure that that vaccination is practices are becoming more customary for that group. But it is something that we wanted to point out of note during the time frame, that there were disparities between the lower 5 to 11 and 12 to 17-year-olds. Next slide. And then we saw as well that booster coverage, when we took a look at booster, not just primary series, but booster coverage was similar in both urban and rural areas. You have kind of this evolution where early on with primary vaccination, primary series vaccination, you see greater disparities between urban and rural counties. But once we moved into the phase of booster vaccination, those gaps tend to close. And so it's very interesting. I think there's a number of different things we may be able to attribute this to. For the purposes of our analysis, we didn't dig into those things. But I think that, as we all are aware, by the time boosters started to actually come out and be available, I think things had changed within the public sphere in terms of an appetite for vaccination, as well as just some of the different vaccination practices that people were choosing for themselves and their families. So I think that, it's very interesting that that gap closes in the booster period. Next slide. And so here I just wanted to make sure, after capturing the very high points of our analysis, that we talked a little bit about the methodology and how we were able to actually attain the results from these analyses. So for the very first time, CDC was able to embark on an effort where we were able to collect vaccination uptake information from all 64 jurisdictions in the immunization program, from pharmacies, as well as federal entities, such as the Veterans Administration and DOD, et cetera, in the country. And so immunization information systems were utilized to collect this information at the state level, as well as our vaccine administration management system, which was utilized as a mass vaccination tool and implemented within IS infrastructure, but also utilized within mass vaccination settings. Or we had direct data submission coming in from our pharmacy partners, sending a direct stream to CDC, but also sending that information to ISs and ensuring that states had the information that they needed. We, of course, looked at folks that were over the age of 5. I had laid out some of the different places that we took a look at and excluded within the analysis in previous slides. But the persons included in this analysis had to have received their first dose during that December 14th, 2020 to January 31st, 2022 timeframe. And of course, using population sizes that were determined by the census, utilizing that as a stable denominator, and taking a look also at county of residences matching at least one of the 6 urban-rural categories, according to NCHS's urban-rural classification scheme. So, similar methods of analysis that are used when looking at anything related to vaccination, but, I think we were able to home in on exactly where disparities were in urban and rural, and start to, again, give ourselves a place for beginning to understand a little bit more about why those things might be happening in the future. So future analyses include digging a little bit deeper into some of the characteristics, and also utilizing things like our National Immunization Survey and other things that can assess vaccine acceptance or vaccine hesitancy, if you will, and reasons why different individuals either didn't get vaccination or didn't feel they had access to appropriate vaccination services. And I think that might be all for my presentation. Thank you so much.
Thank you, Ms. Harris. Next presenter is Brittney Roy from the National Governors Association.
Can you guys, is this working? You can hear me? So I will flag, I'm not that great at slides. That's why you don't have them, partly because I don't know how to put them together. We in the policy space, especially at NGA, we use what I like to call translators. So I say, I need this, and then it happens. And then if they don't do it, then I don't have them. So I have talkers, which I prefer. Maybe not so good for you guys, but hang in there with me and we will get through it together. So like previously stated, my name is Brittney Roy and I serve as the Program Director for Public Health at the National Governors Association. Prior to joining NGA about 2 years ago, I served as the Senior Health Policy Advisor to Asa Hutchinson in Arkansas. So I was there March 2020 when we did our executive order for our public health emergency. And I don't know about you guys, but once this is over, I will need therapy. So I am sure you guys are there with me. How many of you know about NGA? Oh man, it's more than I thought though. Okay, so I'm gonna make sure I don't get this wrong. So NGA, founded in 1908 by Teddy Roosevelt, and we've evolved into an organization today that serves 55 governors, that's states and territories. So we have Guam, America Samoa, Northern Mariana Islands, Puerto Rico, and Virgin Islands. And we primarily work to provide bipartisan strategy solutions to our governors. We have two arms, our government relations side, which advocates on behalf of the governor's offices, and then the center side, which is where I sit, where we work to provide policy and their extra set of arms, kind of like a consultancy. My team, the public health team, I say public health is everything. I'm a little biased. It touches everything. So population health, infectious disease, chronic disease, the whole gamut. Y'all are public health people. I don't have to tell you about it. So the center, like I mentioned, we run the whole gamut of the policy for NGA. So enough about that. I'm going to get to what I was brought here to talk about, which is the work that we did on behalf of our governors in collaboration with CDC. It's a cooperative agreement. Focusing on vaccination strategies. Within that bucket, when COVID came, CDC reached out, and I'll say this cooperative agreement, it's a little give and take. We say, this is what we're hearing from the governors, and CDC says, this is what we need, and then we help them figure out how to make it work, because you guys know that this, has been a little crazy here. So the Vaccinate with Confidence, that's the project that we worked on. CDC said, we can't figure out what's going on in the rural areas. I don't know if you guys can tell, I got a little bit of a draw. My state, Arkansas, very rural. And so I was like, this is my zhuzh. We can do this. We can help figure it out. I was familiar with a lot of policy advisors in some of those states, just from working in my prior role. Our team got together and said, how do we increase vaccine uptake in these rural communities? I will point out to you guys that we had, when we put this project up, 3 major themes kept appearing, and that was access, streamlining systems, and communications. By show of hands, how many of you live in rural areas? Oh, nice. Okay. How many of you, so you live in rural areas right now? Nice. Okay. How many of you have a pharmacy near you? Even in that rural area? 4, I like it. It wasn't until I moved to DC that the pharmacy was it's a 3-minute walk, right? It's in the grocery store. It made sense. I know that pharmacist, not advocating for pharmacists here, but it was convenient. So when we set up this project, we reached out. My connection to the governor's office is through health policy advisors. They're the ones making the policy decisions in the office. They're the ones briefing the governors on what to do. And they're the ones that come back and tell us the feds aren't getting this right, or this is the help that we need, et cetera. So through that, we reached out and said, who in your state do we need to talk to? So it was the immunization managers. It was folks in the gov's office. It was the health department. It was anybody that was touching COVID at the time. So I'll flag for you again that when I moved to DC, pharmacy right across the street. Back home, although I lived in suburb, pharmacy not so close. Folks in my family who were not in the city, you're talking 20-minute drive time, maybe 30 to a pharmacy or a vaccination site. You're talking 40 minutes to a medical clinic to receive care. Let's not even get into food access issues and built infrastructure and environment, et cetera. And so that was a lot of what we were hearing. Arkansas, we have a centralized health department, right? So Gov's office, everything trickles down. Not all states are like that. That was a new thing for me coming to NGA. What we saw was that you have Gov's office, you have a health department, but then some states have decentralized health departments. So trying to figure out how to loop in the local health departments with vaccination rollout, et cetera, presented its own challenges. I will flag that through this work, we worked with states to think through how to increase local availability to vaccination. So the Alabama Department of Public Health flagged for us that they were partnering with the State Area Health Education Center office to set up 5 regional vaccination sites. And more importantly, they were connecting those vaccinators to Gov's office to make sure things were streamlined. The Indiana Department of Health partnered with EMS workers to service high-risk homebound individuals who wanted the vaccine administered in their own home. That was something we saw a lot when we talk about like trusted messengers and trusted partners and things of that nature. Again, my family that lives in smaller towns, you trust the people that you see often. You don't trust big government. So if someone is coming in that you trust, whether it's your pharmacist or the EMS person that you bump into in the grocery store, those folks were more likely to receive the information or even consider the vaccine. And then I will flag that another, I guess, like trending theme that we saw, we've all heard about this. It was the use of a trusted messenger to combat misinformation and things of that nature. And trusted messenger in the form of not big celebrities, but local hometown heroes, if you will. And then we saw that a lot of our governors used their executive power to remove the policy barriers in the form of scope of practice. So a lot of community healthcare workers, those EMS individuals, and then we saw under the PREVENT Act at the federal level, pharmacists were brought in to help with some of those issues as well. One thing that used to get me, I know on our end, we had a lot of states say, we don't want to open the vial. It's too big. We don't have enough folks coming in. So when we open it, it will go to waste. And so we saw some waiting to like pool the appointments to get as many people in as one day. And then some that maybe just did not give it. And so on NGA's side, we worked closely with the administration to advocate for smaller vials. It did not happen as quickly as we wanted it to happen. And so we saw, like states do naturally, our governors, some of the states began to take creative action and figure out, and I don't want to misspeak here, but somehow they made the vials smaller in the health department to not have waste. I will also flag through the communications piece, and we are continuing this work a lot. And like I said, we do bipartisan strategy. So we had both sides mentioning we have a real communications issue. We have an issue in the way that public health is communicated to individuals who may not, have been very involved in public health. So we took that information and said, okay, we'll go out and find behavioral scientists who have done this and are way smarter than the folks working on this. So we found a group, the Behavioral Insights team, who had been working with mayors, and we're continuing to partner with them to help us think through communication strategies and what that should look like and how we should talk about vaccines, how we should talk about communicable diseases or vaccine preventable diseases, et cetera. And so, again, a lot of information that came out of these meetings is people on both sides did not trust that the information they were given was in their best interest. I will flag, I had some of those individuals in my family just for a natural distrust of government. The more I learned and shared information with them, the more they became comfortable with being vaccinated and trusting that the information that was coming out of CDC and the White House was for, the benefit of them. We also saw places like Maryland partner with local barbershops and beauty shops to address vaccine concerns. We saw our governors go through and set up town hall meetings to listen to folks in rural areas and meet them where they are, as we say. And then we also saw that our states worked with localities and county fairs and things of that nature to provide information to their residents. I will flag another issue. So again, with NGA, everything we do is to serve our members. And so that is what I like to call the convening powers of the governors, right? Our governors are really good at saying, this is the problem. How do I fix it? Or I don't know the problem. Tell me how we should fix it. So NGA does the same thing. When we were hearing a lot of these concerns, we worked very closely with organizations similar to ourselves, ASTO, NACCHO, NCSL, et cetera. I will flag that one of the things out of this body of work that we are continuing to work on, not just the communications piece, was just how bad our systems did not speak to each other. So the interoperability was not there. And you'd be surprised, the more we dug into it on behalf of the governor, if you will, the more we realized that even some of the things within a health department did not talk, if you will. I can remember days where I'm like, the hospital bed count didn't update. Why didn't it update? And it's like, well, we checked this system, but that system didn't talk to this system. And then a lot of digging through it. Our epidemiologists, who we used to call our wizards, hate it as quickly as the quick turnaround that we needed for the information. And part of the bigger issue is whether systems did not talk. That's my long-winded way of saying NGA heard those concerns, and we have begun to think through what does public health infrastructure reform in the form of data interoperability look like for our states, as well as the communications piece. We are thinking deeply about what does communicating public health look like in the future. And so we will continue that work with Behavioral Insights team and some other individuals. And I will wrap my time because I don't know how long I've been talking and I want my friends here to be able to speak. But in long story short, if I can take a personal point of privilege, being from a rural state, a lot of these things to me are no brainers. Like, it was before COVID. We knew we had the access issues. We knew we didn't have the resources. And so it should not be a surprise to us that uptake may have been a little slow, whether it was from distrust of government or just because the physical infrastructure was just not there. And I think the work that we did with the states reiterated that. And so we are excited to continue that work to think through how we get our rural states resourced at the same rates as our urban areas. Thank you.
Thank you, Ms. Roy, from a fellow Arkansan as well as the chair. Our next presenter is Siman Qaasim from the Arizona Department of Human Services.
Thank you. So I'm Siman Qaasim, a Health Equity Administrator for the Arizona Department of Health Services, here to talk about being that only state that had the higher rate. And I will say it was a bit more of a spread between rural and urban. If you see here, a little bit of a messy slide, but the 7 very rural counties that contributed to this higher rural rate also had very high social vulnerability index. Do you guys know what that is, or should I? Okay, had very high SVI scores, with the exception of Greenlee, 0.9 or close to 0.9 and above, and then very high rates population of American Indians, Native Americans, and Latinx Arizonans. So one would expect to see quite the opposite, a lagging in vaccine rates for counties that are very rural, very high SVI, very high minority population. But in fact, we saw the opposite. So like many other states, we did have a data-driven strategy. We have very large counties, as you can tell. So county level vaccine rate data was not going to cut it. We worked with our GIS team, and we have a data equity coordinator in our office to create a vaccine planning tool for counties. We're a decentralized state, for counties as well as some of our statewide partners. And we also we picked our top 3 opportunity census tracts within each rural county that had the highest SVI but the lowest vaccine rate, and really did a multi-million-dollar media strategy, which included, of course, all the geo-targeting and all the digital, but also included door-to-door delivery of flyers and whatnot. And of course, was featured in Spanish. Let's see. And then our vaccine equity coordinator, because we had someone just dedicated to this, was able to provide one-on-one TA to the rural counties. And we had data sharing agreements for that census tract vaccine level data that was protected in Arizona for those partners. So, and that's not too different from most other states. We also mobilized on the ground partners. Arizona is actually where the community health worker, I think you guys probably know what community health workers are, promotoras de salud, which are members of the community, lay members of the community that work and are embedded in clinical settings and public health settings. So Arizona, actually rural Arizona, is where that movement or workforce really got its start. So it's very robust and a very strong tradition there. As well as we, of course, had a CDC disparities grant, but because our more populous counties had their own separate grants, the state grant was exclusively focused on rural and tribal. And so I think that focus really helped energize us there. And then, of course, we had our mobile vaccine program, our vaccine equity task force. We did focus groups all across the state with the Mayo Clinic, as well as some of the universities with ethnic minorities to look at what are the drivers of hesitancy, as well as what would be effective messages for our actual communities in Arizona. And then we worked with the Arizona Center for Regional and Border Health, as well as the Arizona Center for Rural Health out of U of A. But really the story I want to say is that tribes have really driven the high rural vaccination rates in Arizona. And I really want to call that out because tragically, we hear about the, disproportionate morbidity and mortality of American Indian, Native Americans, and Latinx Americans with COVID. But I think what I'd like to highlight really is the strong community response to this in Arizona. So Arizona has 22 tribes. We have the 3rd highest American Indian, Native American population in the country, as well as 28% of our lands are tribal. And even though the MMR came out in March of this year, it's the latest data I just want to highlight from Navajo County, which is one of the largest tribes in the nation and actually spans across more than just Arizona into our neighboring states. The rate out of the Navajo County for 5 to 11 vaccine is 50% versus 31% nationally, as well as the 12 to 19-year-olds, 76% versus 60% nationally. So tribes continue to have a strong success. Why? Oops. So I think one thing to note is that through IHS, tribes really have a strong history of especially childhood vaccination rates in Arizona. So this is really building on a strong historical vaccine rate. Well, you'll see in some cases higher than with white Arizona children, and as well as adult vaccine. Sovereignty of the tribes really allowed tribes to have their own unique responses that were at times more stringent and independent from the state response. Also suffering great losses. So I talked about those high mortality rates. And of course, with COVID was with older Arizonans or older Americans. So that's a loss of elders in the tribe, which is particularly tragic, really across our state. And then the tribes, of course, 22 tribes are 22 different communities, but I think overall there was a choice to have very transparent communication with their communities, sometimes more transparent than you saw across the state. And then I think we've heard to a value system that favors community responsibility. Again, I just want to say, of course, tribes are different and they have different traditions and cultures, but there is sort of a connecting theme around a community-centered value system. So in talking with some of tribal leaders, for example, this is a lengthy quote from Navajo Nation or Diné Nation. Janelle really talked about, we already had on the ground partners mobilizing for flu vaccine pods and had this sort of this sophisticated orchestrated infrastructure. And so that when COVID hit, that really paid off in terms of being able to roll out vaccine in, of course, hard to reach areas if we're talking about rural. Touching on the sort of sophisticated, I would say, campaigns around vaccine really emphasized the more community values. You can see with San Carlos Apache, for you, for me, for all. And then, oops, on the next slide, really using Native voices. So rodeo stars for campaigns aimed at youth, campaigns using elders. Really the message, for example, here again with San Carlos Apache tribe was, elders have gotten us to this point. It is up to you now to protect our future. So really culturally relevant messages. And of course, deploying all the best practices in terms of communication, one-on-one assistance and incentives. We heard from one of the tribes that was presenting at our vaccine equity task force that tribal members would fly in from other states like California to get vaccinated at home. So that's how really impactful I think that those messages really were. This is Tuba City Regional Health Center. Again, featuring Native voices, messages developed by various tribal communities for their own communities, I think was particularly effective and really mobilized strong immunization. Then moving over to the western and southern parts of the state, I'll just touch on before I go, which is, again, really using, working with the Regional Center for Border Health that works along the entire western part of our state, but I'm highlighting La Paz County here because, again, of its very high SVI, extremely difficult to reach population. Lots of folks who do not live in traditional housing, lots of folks who, just experiencing extreme poverty. And you can see the very high SVI rate, as well as about 50% of the population is either Native or Latinx. But through the Regional Center for Border Health, which already, again, one of the early folks who to really embed promotoras de salud in their mobile clinic sort of workforce. They had 6 mobile units that are already known to those communities, already go to those communities for regular preventative and primary care. We're really able to dispatch into those communities and make headway with vaccine rates. Of course, they already had a tradition of vaccinating migrant farm workers. So showing up at 4 a.m., showing up at 10 p.m. before and after folks went to the fields to work was another strategy by the Regional Center for Border Health. Down in southern Arizona, University of Arizona Center for Rural Health had its own mobile vaccine program, separate actually from our state mobile vaccine program. And again, when you're working with a community that high incidence of poverty, really targeting essential health workers, migrants, seniors, low income housing is key to penetrating and getting high vaccine rates. And I just want to point out, so down in the bottom is Santa Cruz County. And if you look at our state COVID dashboard, we don't cap it at 95% like the CDC. So we have 151% vaccine rate, which just speaks to some of the condition in Arizona, which is folks come to Arizona who live nearby across the border, whether it's in California or Mexico, to work. And so the numerator is going to be smaller, but recognizing that the population of Santa Cruz, populations of La Paz, Mojave, Yuma, expand during the agricultural seasons and then contract. And so knowing that you have to hit that workforce is key to getting 150% vaccination. And so that's it. Thank you so much.
Thank you very much. Our next presenter is Dr. Matt Willis from the Marin Health and Human Services County Approach.
Thank you. It's an honor to be here. I want to start by recognizing that I'm representing a large number of people that worked very hard in Marin County to try and achieve vaccine equity, particularly in our rural West Marin community. I'm going to start by offering some context pre-COVID for what our experience in Marin County. We, in 2014, had some of the lowest vaccination rates in the state of California. Only 75% of our incoming kindergartners were fully vaccinated. We had the highest rates of personal belief exemptions against required vaccinations in the Bay Area. We had record numbers of whooping cough cases. And in 2015, when we had measles cases, we were sort of highlighted in national media and in national dialogue as being sort of this, the poster child for this, affluent, highly educated community with low vaccination rates. And in fact, Jon Stewart called us out and said that, those people in Marin County are more afraid of gluten than they are of smallpox. And it was kind of like, touche. But it really stimulated some soul searching for us as a community and some new forms of dialogue. And through a combination of policy and dialogue and access, now we have 95% of our kids coming into kindergarten are fully vaccinated, and we have some of the highest vaccination rates against COVID-19 in the nation. About 90% of our kids from age 5 all the way up to 18 are vaccinated. I can't stand here and tell you exactly how that happened. It's obviously complex, and it was culture change. We basically moved from being a vaccine hesitant community to being a vaccine seeking and vaccine friendly community. Obviously, it had a lot of different factors associated, but we did have a strategy, and we tried to apply a discipline to this that I'd like to share, and how we actually applied that to achieving vaccine equity in Marin County for COVID-19. Sorry, there we go. So the way we've been approaching this, some people call it kind of user-centered design. It was just, I see myself, the local health officer as kind of a bridge between you all as sort of national leadership and households. And the easiest way to sort of tell our story, I think, is to start with a family. So this is a family living in rural West Marin. This is a photography project around highlighting families in this community. And let's just think through together kind of what some of the barriers to vaccine are for this family. Some, language, many are Latinx, technology, transportation, health literacy, trust in government, sometimes around immunization issues, and access to healthcare. So any one of those is significant, and taken together can really feel overwhelming. So this really gets down to our core equity challenge when it comes to vaccine equity, which is we're dealing simultaneously in two domains. One is establishing trust, and the other is practical issues around access. And the question for me is, this is not a sort of an academic question. This was a very practical, real world question for us. February 2021, the vaccine here, there's that family. What do you do? And we brought that to the community. Basically, we knew that we as government weren't in the best position to answer all those questions, but we knew that the resources might be in the community. To what's been already discussed, the trust that had already been established in that community, we knew needed to work through those partners. And this just shows when we place the family at the center, that the obvious most proximal influences over families, just in terms of thinking and also in terms of access, are in the community that surrounds them. And we as a local public health agency have a unique opportunity to influence those who are closest to that family in terms of the community. And you see, state and federal agencies are it's very difficult for federal and state agencies to actually access and gain trust through direct communication with families. That's up to us. So these are the three, we've talked a lot about, establishing partnerships and establishing trust. And what I'd like to do is try and offer some of the specific structures that might be spreadable, the specific strategy we used in Marin. So we formed 4 community response teams, or CRTs. These are essentially community coalitions in our 4 hardest hit communities. One of them was in rural West Marin. And we supported them through CARES Act dollars, one lead agency in that community to rally and recruit other partners within those communities to be vaccine champions and to address very specific issues that might be coming in one community or the other. And we supported those communities as a health department through 3 primary strategies that I'll review. The first was using local data for local action. I'm going to say something very obvious, which is that to close gaps, you need to see them, right? And that's a data issue. So you have to stratify. So our wizards, our epidemiologists, were constantly looking at the data and stratifying it in any way that seemed meaningful, whether it was census tract, gender, race, ethnicity, age, to determine where the gaps were. And we set very clear goals with these community response teams about what we were trying to accomplish. This is an example of the data we brought to the CRTs on a weekly basis. What you see in rows are every city and town in Marin. And we had set a goal that no city or town would be more than 10% behind the county average. So what that did was allowed us to have an equity focus, because you're constantly focusing on the tailing end. We don't really worry so much about those who are ahead. It's not an equality approach. It's not a single approach to the whole community, but it's really constantly focusing and tilling that to shepherd everyone along at the same rate. And we're also stratifying by race, ethnicity, and other categories. The next big strategy was communication. This was our most important strategy for establishing trust. And what this shows is, this is what I see as sort of the sequence of trusted information. Starts at the federal level. Take an example, 5 to 11-year-olds are now eligible for vaccine. FDA, CDC comes down to the state. Rob Schechter talks to me, right? This is our California Department of Public Health. I'm the local health officer in California. It arrives intact and trusted by the local health officer. And then the conversation changes, because that's where we're actually able to have bidirectional dialogue. It's the first time in that chain where you're actually able to engage people in households directly. So what we do at the local level is we set up conversations. So we set up meetings. We actually have dialogue. We're actually able to hear and listen and adapt to say, what does this mean for us as a community? How will we roll this out here? And how can we be responsive specifically to people's concerns? Another important element of communication was just, basically having a structure that we established weekly. So these are the sectors that we had. Basically, like my deputy health officer, Dr. Lisa Santora, who's incredible, and I spent a lot of time in just these very structured weekly communications with key sectors, with the schools, with law enforcement, with our volunteers, our board of supervisors, the community response teams themselves. Healthcare. We met with hospitals and health clinics every single week, and just an hour-long meeting to be like, here's where we are with the pandemic. These are the key messages for the week. And I think the most important thing for this was really developing those weekly messages so that we're all aligned, so that family is encircled by the same message, basically, no matter where they go, as much as we can, to manage kind of the countervailing influence of misinformation. And then another important strategy was just daily public. We had an email that went out to about 50,000 of our residents who had signed up with daily public health status updates for a while, and now that's weekly. I did a lot of 3 to 5 minute videos, just sort of explaining where we were at any given point. Lots of press releases with an atmosphere of just basically open access to the media, like basically never say no to an interview. Doesn't matter how small, doesn't matter who it is, doesn't matter if it's conservative, whatever it is, talk. And then our website and social media. And we think this strategy did help inspire trust. This was just from a Casper. This was a randomized survey in Marin County that was conducted last month. The bottom bar there shows that about 92% of our residents responded that they had either strongly agreed or agreed with the statement, "I trust the information provided by Marin County Public Health." And the fact that this was conducted last month suggests that we may have actually inspired more trust in our community from the way we responded to the pandemic together. The last element is building partnerships. And this is particularly important for rural areas. And I think it's been alluded to already. It's kind of simple, but effective. And you basically, you got your family, you ask 2 questions. Where do they go every day? Like, where do they go? Just because they're rural doesn't mean they don't leave the house, right? So where are they normally traveling around? Is it to the school? Do they go to the food bank? Do they go to sports event? Whatever it might be. That's your list access, because you've already addressed all the barriers to access there, because they're already going there. The next question is, who do they trust? right? Who have they established trust with? And the overlap between those two are your most natural partners for both being champions of vaccine messaging and actually offering vaccines themselves by way of access. And this is what our West Marin community response team organized for us based on this strategy. This was that family in West Marin, and those are the specific sectors in that community where people were actually both getting, sort of vaccine positive messaging and actually going for vaccinations. An example of, what we wouldn't have necessarily thought of without the community response team was the food bank. So a lot of these families, low income, were actually taking advantage of the food bank. Food bank, a very natural partner, but not one I would necessarily thought of from a public health standpoint. And the flow and the very process are very similar. People come, they get the food, and then they go. So you can put vaccine operations pretty easily into that setting. And they're also, offering materials, they're offering foods, you can offer pamphlets, whatever it is, and information, and then they actually become mouthpieces of the messaging itself. So that's an example of how in West Marin, people were getting messages and vaccinations from both trusted and already accessed agencies. And this is just a picture of, a vaccine clinic at a school in West Marin, a celebratory atmosphere. And then some of the messaging that was derived from what the CRT in that community thought would be important messaging in Spanish, showing a resident of that community. These are the results in West Marin. So we had, by August of 2021, 98% of our Latinx residents in West Marin were fully vaccinated. And we saw a corresponding decrease in the disproportionality of cases. Latinx residents were 7 times more likely to be infected in 2020. And that has now been sort of normalized to be about 1-to-1 with their white counterparts. So in summary, achieving high vaccination rates equitably requires a simultaneous focus on building trust while removing barriers to vaccination. In Marin County, we used community coalitions called community response teams and public health to partner, and we advanced COVID-19 vaccine equity together with 3 strategies, using local data for local action to describe disparities and set shared goals to narrow them. We communicated for impact by fostering trust, by listening and learning. And that, I think, was the most important element. If we go back to what changed in Marin County between 2015 and 2020, was a difference in the approach to the vaccine conversation itself, which was actually stepping out of our offices and getting into communities and listening and recognizing that the decision-making, it's a lot less about what I think and more about what they think if we're trying to change hearts and minds. No one changes their mind when they feel defensive. And so having a different kind of conversation and then delivering frequent, consistent messages across sectors. And then finally building partnerships, starting with existing circles of trust, especially in rural areas, for both access and messaging and operations. And I want to thank everyone who helped contribute to this slide presentation, but also to the effort itself. And just end with, this has not been, on the ground, for those of us, this has not been easy work. This has been a really challenging couple of years. And if it wasn't for just the support of the team, I think that's another best practice. Should put that as the 4th strategy, is just supporting each other through this and celebrating small successes everywhere you can. Thank you.
Thank you, Dr. Willis. Our final presenter in this panel is Dr. Keri Rath from the Fabulous Ladies Book Club.
All right, I get a clicker, which makes me kind of happy. Hi, thank you for having me. My name is Keri Rath. I am going to introduce myself and tell you a little bit about where I live and what I do. And then I hope that I can give you some sense of what we achieved in our community as part of a big volunteer effort. I realize I'm speaking last on Friday afternoon, and I'm standing between you and the weekend, maybe happy hour. So hopefully you'll find it entertaining, maybe a little uplifting. I am a practicing OB-GYN. I work at Lincoln County Medical Center in Ruidoso, New Mexico, which, if you're a little bit familiar with the geography, is about halfway between Albuquerque and El Paso, about 60 miles east of I-25. So you take a left if you're going from Albuquerque, and you drive through a lot of nothing, including a stretch of no cell phone service, and you arrive in Ruidoso. I am one of 2 practicing OBGYNs there. We serve a critical access hospital with 25 beds in the middle of a care desert with about a 50-mile radius between us and the next hospital. All right. Forgive the fact that I wrote the wrong year. I'm going to blame the COVID time vortex and homeschooling. Homeschooling plays a role in this because it was awful. In the summer of 2020, my husband, Dr. Stephen Rath, who we'll call Steve from here on out because calling him the other Dr. Rath is confusing, was deployed for COVID response with the New Mexico Air National Guard. He is an anesthesiologist by training. He is currently about to be penned as a lieutenant and is the SGP of the 150th Medical Group. He was the liaison between New Mexico's Armed Forces or Reserve Response and the New Mexico Department of Health. In that role, he became acquainted with a woman named Dr. Aja Sanzoni, who was the coordinator of the infectious disease response for the New Mexico Department of Health. And in December of 2020, we were headed to that vacation, which was the first one we'd taken in a really long time, to go ski on the side of a mountain, and the phone rang. And it was Dr. Sanzoni asking Steve if he had any idea how we could put vaccines in arms in our little town. So we had a number of barriers to vaccine delivery. In Ruidoso, the vaccinations that we were using in the county were being delivered to healthcare workers first through our local hospital. That included our first responders, but they were doing everything they could, putting vaccines in arms, and they could only service those of us who worked at the hospital and the first responders. There wasn't a big enough labor force. The County Department of Health had 2 full-time staff, and they were fully utilized in testing efforts. They had no capacity to vaccinate patients. And supply, the local pharmacies weren't receiving vaccines from their parent organizations, and the reimbursement for them was unclear. Steve's office, interestingly enough, has a minus 80 degrees Celsius freezer because some of the procedures that he does within his office. So we had our location. This is my husband's office. It's built as a straight shot from the front door to the back. You can walk in the front door. You can take your choice of 4 rights into rooms and walk out the back door around to the parking lot where you can wait in your car for your 10-minute waiting time. These are my book club ladies who we called the day after we got the phone call. This is a group of women, and of course their spouses got roped into it, who are community active. We are teachers, we are vets, we are people who work in the technology sector, pharmacists, and we called for help and said, we'll serve mimosas. Come learn the computer system. We can all give a shot, can't we? And they showed up. And then the supply. The Department of Health had Pfizer vaccines sitting on the shelves that were going to expire. And we were one of the few places that could store them because of this happenstance minus 80 Celsius freezer. So the vaccines could come to us and we could use them. This is a picture of vaccines and syringes in our draw room and me giving one of a bazillion vaccines. We certainly faced several challenges in the process of our vaccine delivery, even though we had the location, the labor, and the supply. First, we started in January in a little mountain town. The elderly population was being vaccinated first, and we had snowstorms. We would set up a vaccine clinic, and we'd have snow and ice. In a town the size of Ruidoso, which has about 10,000 people, typically you can call the mayor and say, Lynn, please help. We need someone to come clear snow and ice. And he did, and they helped provide traffic redirection, control, roadway management. We called local restaurants who weren't able to work at the time and said, can we borrow your heaters? These people are lined up outside and they're cold. And they brought them. And then for patients who were unable or immobile, we actually had vaccine teams who put on their snow boots and went out to the cars and vaccinated them through windows. At the time that we launched, the New Mexico Department of Health had launched a vaccine registration and scheduling system. this was an ongoing system. So we gave our first vaccine, I believe, on January 3rd. It was an ongoing effort. So we ran into some technology problems, of course. One of them was that the codes that were given to us to use as a scheduling tool in a town the size of Ruidoso got out. And before we knew it, we had lines of people who had signed up who were not eligible necessarily to vaccinate. But you don't run them off. Probably. You just kind of look at them and keep putting one foot in front of the other and think that every vaccine and every arm helps every person. It's hard to throw people out of your vaccine site. So we didn't do that. This is Liz, who actually she telecommuted with Soundhound in San Francisco and worked on the tech side. So every night she called Chris. So one of my book club friends called Chris, who was the computer person, and said, Chris, this is the problem we had today. And so Chris and his team would update the computer system every night. Again, equitable distribution certainly became a challenge in a town the size of ours. I already spoke to the computer registration and scheduling. There wasn't a lot of Spanish language support. That's my mother, who's a retired Spanish teacher, who became our Spanish language support. The libraries were closed. If you didn't have a computer, you couldn't register. Technology is always a double-edged sword. We spent a lot of time on the phone. We spent a lot of time talking to the mayor's office. We set up a call center to help those elderly people who could not register themselves. We had a little bit of political interference from our governor's office, and I am not saying that the governor did a bad thing. But in the process of the codes getting out, there was an article in the paper that said that we were giving vaccinations out of order. And then through some back channel discussion with military contacts with the pharmacists or the pharmacies that were just delivering the vaccines, my husband found out that we were not going to be sent anymore because we were going out of order. So he called someone else in his back channel who he had worked with to get Q-tips from somewhere during testing with the guard and said, that's not what happened. And they said, well, just kidding, here, have some more vaccines. Shortly after we started this effort,